Kaschela, Holland, a third-year PharmD candidate from West Palm Beach, Florida. I will be presenting a journal club titled Ezetimibe Added to Statin Therapy for After Acute Coronary Syndrome. This article was funded by the manufacturers of Vytorin and Zetium. In this article, having increased levels in cholesterol increases more incidences of experiencing a cerebral vascular accident, which is a stroke, and heart disease. What is cholesterol? Cholesterol is a waxy and fat-like substance that is found in all the cells within the body. Cholesterol is divided into two types: low-density lipoprotein, which is LDL, and high-density lipoprotein, which is HDL. Studies have shown that cholesterol contributes to the arrangement of cell walls. It produces the gastrointestinal bile acids in the intestines, and it permits the body to generate vitamin, and then it permits the body to generate specific hormones. The optimal levels of LDL is less than 100 milligrams per deciliter. High is 190 milligrams per deciliter and above. The purpose of statin therapy reduces LDL levels in the patients with and without cardiovascular disease. Statins act by competitively inhibiting the HMG-CoA reductase and the first committed enzyme of the mevalonate pathway. The drug ezetimibe, it blocks the absorption of cholesterol in the intestines. This leads to an increase in LDL cholesterol receptors in the liver. As a result, these receptors then remove LDL from the blood. The objective of this study: statin therapy reduces low-density lipoprotein and the risk of cardiovascular events. But whether the addition of ezetimibe, a non-statin drug that reduces a drug that reduces intestinal cholesterol absorption, can reduce the rate of cardiovascular events. Further is not known. This study was done between October 26, 2005 and July 8, 2010. A total of 18,144 patients underwent randomization at 1,147 sites in 39 countries. 9,067 patients were assigned to simvastatin monotherapy group and 9,067 to simvastatin ezetimibe group. The study was a double-blind study, a randomized trial involving 18,114 patients who had been hospitalized for an acute coronary syndrome within the preceding 10 days and had LDL cholesterol levels of 50 to 100 milligrams per deciliter. If they were receiving lipid-lowering therapy, or 50 to 125 milligrams per deciliter, if they were not receiving lipid-lowering therapy. This location, it took place, like I said before, over in 39 countries. The inclusion: men and women who were at least 50 years of age, hospitalized within 10 days for acute coronary syndrome, LDLs of 50 milligrams per deciliter or higher. Exclusion: planned coronary artery bypass grafting, creatinine clearance of less than 30 milliliters per minute, acute active liver disease, use of statin therapy greater than 4 milligrams of simvastatin. Primary endpoint. The primary efficacy endpoint was the time for randomization until the first occurrence of any event in the composite endpoint. This included the CV death, major coronary events, and non-fatal strokes. The secondary endpoint. The secondary efficacy endpoints included the time from randomization until the first occurrence of composite incidences of death due to any cause, major coronary events or non-fatal stroke, composite endpoint of CHD death, non-fatal myocardial infarctions, or urgent coronary revascularizations with either a PCR or a CBG occurring at least 30 days after randomization. A composite of endpoint of CV death, non-fatal MI, document unstable angina that requires admission into a hospital. The follow-up. Every patient had to visit day 30 after 4 months. Duration minimum 2 years, 2.5 years follow-up at least 50 events. Statistical analysis. In the final protocol, we estimated 5,250 incidents will be required to give the study 90% power to detect a 9.375% lower relative risk for the primary endpoint with simvastatin and ezetimibe than with simvastatin monotherapy. All efficacy and safety analyses were performed and intended to treat population. Rules for stopping the study early interim analysis were pre-specified. The Data and Safety Monitoring Board conducted 10 safety reviews. In addition, 3 interim efficacy and analysis were performed. After 45.7%, 76.1%, 86.9% of the required events had occurred. Adjustment of the level of significance to account for the 3 interim analyses were determined. The baseline characteristics. The mean age was 64 years old. Age weight, 83 kilograms, which like 182.6 pounds. This was for predominantly white, which is Caucasians, and that was 84%. The gender, 24% were women and 76% were men. Coexisting conditions. Diabetes, 27.3%. Hypertension, 61.3%. Congestive heart failure, 4.1%. Peripheral arterial disease, 5.7%. Adverse events. Some common adverse events involve elevation of the LTL and the ASTs, and occur in 2.3% of simvastatin monotherapy group versus the 2.5% of simvastatin and ezetimibe group. Some serious adverse events: cancer occurred in 10.2% of all patients, and death from cancer seen in 3.6% of simvastatin monotherapy group versus 3.8% of simvastatin and ezetimibe group. The percentage that discontinued due to adverse events. Out of simvastatin and ezetimibe group, 10% of the patients discontinued compared to 10% in simvastatin monotherapy group. The author's conclusion: improve it. The addition of statin therapy of a non-statin agent, ezetimibe, which reduces the absorption of cholesterol from the gastrointestinal tract, it lowered the LDL cholesterol by approximately 24%. The combination of simvastatin and ezetimibe also resulted in a significantly lower risk of cardiovascular events than with the statin monotherapy, with a 2.0% point lower rate of the primary composite endpoint of the cardiovascular death, major coronary events, and non-fatal strokes. No between group differences in cardiovascular mortality or in the rate of death for any cause were anticipated or observed in improving. Findings that are consistent with those in trials of intensive dose versus the standard dose statin therapy. However, significant reductions were observed in the rates of myocardial infarction and ischemic stroke. Some strengths. Some strengths from this study are an expansion of overall magnitude, far-reaching patient source through various countries, and therapy was long drawn out. Some weaknesses from this journal. It was predominantly white, which was 84%. Authors are associated with pharmaceutical company, which stands to benefit if this drug is more frequently used. Use only 40 milligrams to 80 milligrams of simvastatin as a background statin therapy, which is considered moderate and intensive statin therapy. 42% of the patients discontinued the study medication for any reason prematurely. Overall, this study suggests that ezetimibe added to statin therapy is more effective at reducing cardiovascular events as compared to statin therapy done alone. The increased effectiveness of this combined treatment versus statin monotherapy was only evident after 1 year of treatment. The results of this study can only be considered relevant toward patients who had an acute coronary syndrome, as these were the only patients included in this study. This study suggests that ezetimibe added to the statin therapy is more effective at reducing cardiovascular events as compared to statin therapy alone. That concludes this journal club of ezetimibe statin therapy after acute coronary syndrome. Once again, I'm in Kaschela, Holland, a third-year PharmD candidate from West Palm Beach, Florida. Thank you.